Good morning, ANZGOG. Kia ora, New Zealand. Thank you so much for your invitation. It's my real pleasure to be with you. Be careful with my accent and my English. I'm probably the last one in this room not able to speak English as you, so sorry for that. Considering my disclosure, unfortunately I have no disclosure to declare for heart cancer. I would like to have, but it's not always easy to have some conversation with pharma company. The question we address today is, do we need to have clinical trial or registry dedicated to heart cancer? I would like to say why we need to choose. We need both. Why? Because unfortunately heart cancer become a big issue for us considering survival. We did not have any improvement since long time. Also, these patients represent more than 20% of all cancer patients. It's also more than 30% cause of death in our patients. And why we need to consider this problem is because finally, heart cancer are involved in a negative loop where we have low level of knowledge, low capability to drive clinical trial, no able to improve our knowledge because we don't have clinical trial. It is a low incidence where authorities are not so well interested. Pharma companies are not so well interested. And so at the end, we have low chance to improve the survival of these patients. It's for this reason that we need to continue to fight for them. And the first point is we need to improve ourselves. Why? Because we already demonstrate that when we implement guidelines, we improve the overall survival of the patient. When we develop a large amount of knowledge considering international guidelines, we will be able to develop international collaboration. It is what we've done at the GCIG level. We also know that when we look at the initial diagnosis, when we have a second opinion, we improve ourselves and we will be able to develop better management for these patients. We also know that we are able to develop dedicated network, and I will give you an example soon, who will be able to improve the overall survival of our patients. And this is something that I would like to share with you. We are not speaking about gynae cancer, but soft tissue sarcoma. And finally, when we are able to improve our medical practice, we are able to make the demonstration that we improve the overall survival of the patient compared to the patient who did not receive standard treatment looking to the guidelines. And when you look at the other ratio in this clinical study with an other ratio of 0.34 compared to what the chemotherapy brings in the adjuvant setting with another ratio of 0.82, we can imagine that improving our ourselves is better than giving systematically chemotherapy to these patients. Why about heart, ovarian, gynae cancer? Also, they represent only 18% of all heart cancer. In this particular setting, 50% of our patients are rare. And also, they receive the same treatment since long time. They are completely different. And it is for this reason that particularly gynae community need to be very open and very active considering heart cancer, because at the end it's not so rare. And in this way, when we speak again about this negative spiral, we need to consider two pathways to fight this problem. One is to move to explore all the current evidence we have and to increase our knowledge about all these different diseases. And the second point is to improve everything we can do at the routine practice level to increase our capability to treat this patient. So considering the first point about the current evidence and unanswered question, moving to rare epithelial cancer for ovarian, the key question for the localized disease is clearly about the conservative surgery and the need of yes or not adjuvant care, chemotherapy. In the relapse setting, The point is the best therapeutic option we need for these patients who are in general resistant to platinum. And in this point, we really need a new option for this patient. Why? Because the response rate to standard chemotherapy, you can see, is always very low. Whatever you are looking to the different histology, you can see that compared to high-grade serous ovarian cancer, the activity of chemotherapy, platinum-based chemotherapy, is very low, but it is also very low in the relapse setting for monotherapy. And if we look at all these different diseases, we finally know that all of them share the same resistance to platinum, but the mechanism of resistance is not exactly the same. And if you look, for example, to the low-grade serous ovarian carcinoma, not so rare disease, 15% of our patients, young patients, resistant to platinum. The most important knowledge we have is about ER and PR positivity and KRAS and MAP kinase pathway alteration. And this gives us the great opportunity to test new treatment as MEK inhibitor or CDK4/6 inhibitor in this particular disease. The results of MEK inhibitor were already published 10 years ago, more than 10 years ago, when we see the activity of the selumetinib in this population well compared to hormonal treatment or chemotherapy in terms of response rate or median PFS. And looking to what we observe in this small phase 2, this opened the door to large clinical trial. It is what we see with the GOG trial exploring the trametinib in a large phase 3, positive phase 3 for PFS and overall survival, comparing standard of care. And also the MILO trial with another MEK inhibitor, the biminetinib, where unfortunately the results in the ITT population were negative, but we see a large benefit in this, with this MEK inhibitor in the KRAS mutated population. And so looking to all these results, we consider that MEK inhibitor should be a new standard for our patients. However, in the large part of the world, we did not have access to this MEK inhibitor. And more recently, we have this combination of MEK inhibitor and FAK inhibitor, who report very good results in a large phase 2, who give access to the drug at the US level, but unfortunately none in Europe. And we are waiting for a new large phase 3 exploring this combination compared to standard of care to be able to promote new option in the low-grade serous ovarian cancer patients. Now looking to another example, the mucinous ovarian carcinoma, very rare disease, very complex. The majority of these patients are not primary ovarian cancer, but metastatic from digestive cancer. The prognostic could be good for early stage. Unfortunately, with advanced disease, the results are really bad in terms of prognostic. And finally, when we look at what we need to improve for this patient, for sure, the initial pathological diagnosis, it's important. We see a lot of difference in our French network. More than 30% of the patients have a change in terms of diagnosis with the second opinion. The oncogenic driver is not so well known. Considering the use of adjuvant chemotherapy, carboplatin paclitaxel remains the standard of care. Also, the results in terms of activity is bad. There is no clear evidence about the role of IPEC in this disease, and again, we need to have new drug for this patient. And considering the oncogenic driver, there is recent data considering the KRAS mutation and HER2 amplification, who are really interesting. First, because they are mutually exclusive, considering the presence of such abnormality. And second, there is now treatment available for this target, who can be perhaps a hope in the future for our patients. Now moving to the clear cell carcinoma. It's not a so infrequent disease, looking to the incidence, particularly in the Asian population, more frequently associated with endometriosis. And when you look at what it is in terms of molecular driver, we see that ARID1, P3K, and P53 could be something important to look at in this particular population. And we have now several data to consider new options for these patients. first, we have seen how anti-angiogenic can work in this population, and the question now will be considering tyrosine kinase inhibitor or BEV therapy if we look at the different data and what we have to use in the first line or in the relapse setting. More interestingly, immune therapy. We have several data who consider that this population is particularly enriched in immune cell microenvironment, and when we look at the data considering in the different clinical trials we have seen, is that the monotherapy but also the combination with chemotherapy and BEV can be really interesting in these different clinical trials. However, what it is interesting is we start to see dedicated phase 2. Rebecca Christensen report 2 years ago this phase 2 dedicated to ovarian clear cell carcinoma with a response rate of 25% with pembrolizumab. And we also see the INOVA trial adding bevacizumab to PD-1 inhibitor where the response rate was 38%. We start to see dedicated trial for clear cell carcinoma, including innovative therapy. And we will start soon the DOVE randomized phase 2 trial where we will see immune therapy in combination with BEV compared to immune therapy alone versus standard of care in the near future. What about ovarian and uterine carcinosarcoma? It's much more complex because we are speaking about 2 different localizations, and in general, these patients are elderly. So it's not always very easy to include this patient in our clinical trial. What we see in terms of activity of chemotherapy is very poor. When we look at post-carboplatin paclitaxel, the response rate is close to 15%. The median PFS is 2 months. The overall survival is less than 1 year. There is no clear activity looking to what we see in terms of anti-angiogenic agents. Considering lenvatinib plus pembrolizumab, they are not included in the keynote trial, and the 2 phase 2 already available did not report a huge activity for this population. We don't see activity with PI3 kinase inhibitor in previous clinical phase 2 trial. We see good activity now with the RUBY trial considering immunotherapy in combination with carboplatin paclitaxel, and also good results in terms of HER2 inhibitor, the TDXD, in this particular population. However, the molecular characteristic and more importantly, the EMT able to explain resistance to chemotherapy but also immune therapy need to be explored, and for this we need to have clinical trial. So finally, when you look at all these different examples, you see immediately the diversity. The diversity can be related to histology but also the molecular alteration. And when you look in detail to the molecular alteration compared to high-grade serous ovarian cancer, for example, you see immediately why we have some resistance to platinum. The majority of these patients were HRD negative, but we see also all these different pathological abnormality, molecular abnormality, who give us the opportunity to develop large molecular-driven clinical trial. And probably one of the answers to all these different difficulties considering rare cancer is also to bring all of them in the same trial, looking to what could be the molecular abnormality and try to provide some option for this patient, considering the molecular abnormality we have identified in the tumor block. It is what the Bouquet trial tried to develop for this patient. We include, you will see several patients, and you will see that finally we are able to move forward and to develop a large clinical trial at the international level in accordance with pharma industry for sure. Now moving to the second part about my talk, considering what we can do in routine practice to increase our activity for rare cancer and to improve the survival of these patients. The most important challenge for the patient is really to have access to the right diagnosis, to be able to deliver the prognostic of this patient, to know what about the prognostic of the patient, but also to give them the right treatment, and also to adapt our treatment, and also to anticipate the sequelae. For us, it's really how to improve our quality of care in routine practice and to develop collaboration at the national but also international level. Coming to the right diagnosis, we already published that, unfortunately, when we systematically look at the initial pathological report, we change diagnosis between 12 to 18% in general, and the change in terms of diagnosis have an impact on the management of this patient for 18%. More recently, we start again to analyze the results in 2018, and we see exactly the same over the time. 22% of our diagnoses were changed by our expert in pathology, and the discordance includes something that we will change the management of this patient, 22%. Unfortunately, there is a large heterogeneity, and between 10 to 20% of the major changes have an impact of the medical decision, and unfortunately concern all the histology already mentioned before. What about the molecular tools? We already see that DICER1 and FOXL2 could be something important in terms of diagnosis, but perhaps in terms of prognostic. Now we have more knowledge, we can say that in terms of prognostic it's not really important, but in terms of diagnosis it could be really helpful. And it is something that we include in our network to systematically look at DICER1 and FOXL2 to be sure about the initial diagnosis of our patient and to adjust the treatment for that. What about the definition of the prognostic of our patient, and what this is important to define the best standard of care, what could be the indication of adjuvant therapy, for example, and how to change our guidelines. I will give you the example of ovarian germ cell. They are so hard that finally there is no randomized trial. We are always extrapolating the decision coming from randomized trial in testis cancer. Also, the vast majority of these patients will be cured by surgery and adjuvant chemotherapy. However, when we look more in detail to these patients with early stage, we realize, using retrospective national database, that finally this systematic adjuvant treatment increased the progression-free survival, but not the overall survival of all our patients. And looking to all this data retrospectively published in the literature, we start to consider that perhaps all of the patients did not need to receive adjuvant chemotherapy. And it is what we start to do in 2017 when we update our guidelines, but we continue to work on this topic, and with the GCIG, when we developed the guideline for malignant ovarian germ cell tumor, we introduced systematically surveillance for the non-dysgerminoma and dysgerminoma patients with stage 1, considering that overall survival could be the most important endpoint for this patient. And if they are very concerned about the side effect of the chemotherapy, we can provide an active surveillance and deliver chemotherapy only for patients with relapsed disease. This is something important. What about the quality of the management of our patients? With our national network, we develop guidelines, we implement the network and the discussion of the treatment in multidisciplinary tumor board dedicated to rare cancer, and looking to what we observe in terms of surgical treatment for granulosa cell tumor, this network improves the quality of the surgery, but also the overall survival of our patient. This is something strong to deliver to our patient. When we work all together, we are able to improve ourselves and also to improve the overall survival of our patient. And it is something that we would like to develop also at the European level. This is something that we are ongoing to do with ANZGOG, to merge all our national database, to have a big database for rare tumor, to be able to deliver important questions in terms of surgery, what we need to have a systematic peritoneal staging for all our patients? Do we need to develop more data about the use of adjuvant chemotherapy for granulosa tumor? All of these large database, I hope, will be helpful to answer the question. What about the sequel and the late toxicity, including psychological aspect? This is something important. We mentioned before our side effect we have with chemotherapy, specifically for this population where we have the opportunity to cure this patient. We know about the neurotoxicity, the second cancer, the cardiovascular toxicity, and metabolic and menopausal data. However, we don't have any data for ovarian cancer. And so again, with this network, we was able to deliver a retrospective and prospective database where we asked to the patient who received chemotherapy versus the patient who did not receive chemotherapy, match with healthy women, how is the quality of life of this patient and how is the sequel of the chemotherapy using adjuvant chemotherapy. And Florence Joly already reported the results where we see that there is perhaps some similarity in terms of fatigue, but unfortunately we have a higher risk of premature menopause and impact of the sexual health, for example. What about clinical trial? We already speak about some of them in the first part. We make the demonstration with the GCIG how we are able to move forward also in very hard tumor as sex-caused stromal tumor. We already proposed a randomized phase 2 exploring the use of BEV in combination with paclitaxel versus paclitaxel in this population, and using all the effort at the national level, but also at the international level, we are able to succeed and to deliver this trial already published now in the JAMA Oncology. And I'm very proud of this trial because at the same time, the pharma company tried to develop also a randomized phase 2 for a very nice drug, the CDK4/6 inhibitor ribociclib, who have a strong rationale to be explored in immature teratoma. I try to convince the pharma company to move forward and to work with us to be sure about the recruitment of this patient in the clinical trial. Unfortunately, they did not agree. And finally, the trial fell down and closed due to the low recruitment. That means that we have the perfect demonstration that when we are able to collaborate all together, we have more chance to succeed than when we want to work alone in our place. And effectively, when you look at the success of the clinical trial, also we have negative results. We are not able to make the demonstration that BEV increased the progression-free survival in this population. Also, we see a better response rate with the combination. We increase our capability to demonstrate the feasibility of randomized clinical trial in very hard disease. And now when you look at the number of clinical trials dedicated to rare ovarian cancer at the ANZGOG level, we have more than 20 already open for the patients. Another way is to consider the clinical trial, but not alone, with translational research in parallel. It is what we provide with the Roxanne trial dedicated to carcinosarcoma, where we would like to explore the combination of immune therapy with PARP inhibitor in the relapse setting, looking to the level of evidence with a phase 3 trial. The European community agreed to provide money to develop the large translational research in parallel. And we are able to include biopsy before and biopsy during the progression to develop more information about this very rare disease. I already mentioned the Bouquet trial, who also is something really important for us to consider, a basket trial where we are able to include all the different histology, moving to identify the oncogenic driver and to try to explore the combination or monotherapy in all rare diseases. We worked very well. I just provide you the last recruitment we have, and you can see that at the worldwide level, we were able to pre-screen more than 800 patients in 2 years. Also, we have some issue with the European EVDR process. And you see that every country tried to work a lot, and at the end, we include more than 150 patients in this clinical trial. Unfortunately, the pharma company decide from a strategic decision that it's not interesting to work on rare cancer, and they decide to close the trial before the end of the recruitment. It's a sad news for us, and more particularly for the patients. We will like to learn a lot, and I hope we will be able to publish everything available in this trial to be able to improve our knowledge. But it's a big issue for our patients. Now moving to the international collaboration. I already speak about the GCIG, and effectively one of the important points at the beginning is to be sure that we are the same thing and we are aware to consider the same treatment for our patients if we would like to develop clinical trials. And it is what we done in 2014. We developed 20 clinical guidelines for all our rare gynae cancer, to be sure that when we will be able to discuss with pharma company, they understand how we have the same vision of the management of our patient. We also develop at the European level an ORACAN network. This ORACAN network is dedicated to all rare cancer, not only for gynae cancer, but what we are doing in gynae cancer is to have a virtual MTD dedicated to rare cancer every month, where we are able to discuss about the very complex situation where we would like to have the opinion of all the experts around the world. And it is what we already published last year in the International Journal of Gynae Cancer. We demonstrate that this activity is able to increase our capability to promote active surveillance for 22% of our patients, and also to give access for some of them to off-label therapy, because the European multidisciplinary board promotes some treatment as pembrolizumab for GTD or other example, and looking to what we are promoting, it can be helpful for the physician and the patient to go back to the government and to ask to have access to off-label treatment. We also develop general leaflets, translate in all the different languages, that it is something important at the European level. We are not speaking all English, as you can see with myself. Considering this regional and national management, how to organize, it's really something important. I would like to promote what we do in France. Also, possibly it's not the most interesting point for you, but when we are able to work all together and when we develop this national network with two important things. First, we systematically discuss the medical case of our patient in multidisciplinary tumor board dedicated to rare cancer. There is 22 centers in France who agree to do the job every week or every 2 weeks to be sure that all patients can benefit on the same knowledge and the same expertise, whatever they are living in Paris or not. We also systematically look at all the initial diagnosis. We include more molecular testing, considering SMARCA4, DICER1, FOXL2. We develop workshops for physicians, nurses, but also for public and for patients. And looking to what we observe, we are able to develop research, clinical research, but also fundamental and translational research. All the work is already done on the website, where you are able to declare your patient. We are able to ask for the multidisciplinary tumor board, sorry, it's in French. We also have all our guidelines available on the website and also our database. And when you look at the activity since the beginning, 10 years ago, more than 10 years ago, you see that finally the majority of the patients receive both a multidisciplinary tumor board discussion and a pathological second opinion. Some of them receive only the pathological second opinion because the physician moved to the guidelines and consider that the guidelines is enough for their patient. And for some patients, we don't have this second opinion because it's a relapse and the patient received already the second opinion before. And finally, if you want to develop such organization at your national level, you need to promote the patient advocacy group to help you to promote this activity. You need to implement your own guidelines at your national level. I already mentioned the multidisciplinary tumor board and the second opinion, but more importantly, you also need to have a database. And right now in our database, we have 20,000 patients already included, and this is really helpful for us to develop question, research, but also knowledge for the future. And so if we want to finalize this important talk, I would say that you have to remember that rare gynec cancer are not so rare, they are frequent. And so for the management, you need to have expert pathologists, you need to have expert multidisciplinary tumor board. This common database for registry is much more important. We also need to educate our patients, but also our physicians. We need to develop this international collaboration. Without this international collaboration, any clinical trial cannot be done. And we know now that clinical trials also randomized are feasible. We also know that improvement will come soon. More and more knowledge, we have better chance. We have to negotiate with pharma companies to develop clinical trials and to have access to the new drug. And we have to remember that the tumoral minority is the future in oncology. Thank you so much for your attention.